Thank you for the introduction, and I thank the organizers for inviting me to this very lovely and beautiful place. Now, my topic today is the role of the dermatologist in the melanoma treatment and follow-up. And I have been told that I have a little bit more time because two other speakers did not come. So I also took one of the headphones and I asked the translator to translate questions if we can discuss questions afterwards. Now, I want to give first a very short answer to this question of the role of the dermatologist. The dermatologist shall guide interdisciplinary melanoma management. And so that is at least the role how we understand it in Germany. And so consequently, in the Journal of the German Society of Dermatology has now been published an S3 guideline, diagnosis, therapy, and follow-up of melanoma, and the short version comprises 40 pages of the journal. And so this has been elaborated under the guidance of dermatologists. So Dirk Schadendorf and myself were the coordinators for the entire guideline development process. And this has been published now in June 2013. And it's available in the Journal of the German Dermatological Society. And if you don't get it, just give me an email and I will send you a PDF on this. Now, this S3 guideline, which means it is evidence-based with systematic literature research, and it's consensus-based, was developed under the guidance of the Dermatologic Cooperative Oncology Group of the German Cancer Society in collaboration with the German Dermatologic Society. There were reviews and discussion over a period of 3 years by experts from 24 different disciplines of the German Cancer Society. So the dermatologists were in the minority, but we coordinated the entire process, and the publication was made in the Dermatological Journal. There will be also publications in the German Ärzteblatt, which is a general journal for physicians. The recommendation levels and evidence levels according to other oncology guidelines are given, which means the level of 1 is the highest evidence. 1A means the level of meta-analysis of randomized trials, and lower levels are 2, 3, and so on. And we give recommendation levels. A is the strongest recommendation, B is a little bit weaker, and 0 means a can. We consented 124 recommendations and statements for the diagnosis, treatment, and follow-up of melanoma. And in the following, I will inform you about the main points which were consented in Germany for melanoma management. So, which diagnostic tools are relevant for the clinical diagnosis of melanoma? First, the inspection without technical aid is suitable for the clinical suspicion of melanoma. So we can recognize the melanoma with our naked eyes. However, dermatologists should offer dermoscopy for pigmented skin lesions and should have received an education on dermoscopy. We had a lot of discussion to formulate this recommendation in this way, because in Germany skin cancer screening paid by insurances is or has been established since 2008. And it is also done by general practitioners. So general practitioners do it and dermatologists. But the general practitioners are not trained in dermoscopy. And so it would be not feasible to recommend that also they should use this. So that's the reason why we say dermatologists should offer this technique and should be trained in this technique. Which classification is currently used for the staging of melanoma? And this is the American Joint Cancer Committee classification from 2009, published by Walsh and co-worker in the Journal of Clinical Oncology, which is the standard for classification and for histopathology of melanoma. Probably most of you know this classification with 4 stages, 2 stages for primary tumors with increasing tumor thickness, 1 stage for local regional metastasis, stage 3, and stage 4 is distant metastasis. Which technical tools could improve the clinical diagnosis of melanoma? So the sequential digital dermoscopy can improve the early diagnosis of melanomas in the follow-up if they, melanomas, have no specific dermatoscopic criteria for malignancy. So we just gave a recommendation level B, and there is no randomized study to prove this. But there was a strong feeling from those who practice it that we can recognize just by changing pigmented moles those who have not the total appearance of melanoma. And so let's say it is my understanding that this will be increasingly frequently done in Germany, and there are already nearly 2,000 private office dermatologists in Germany who have this technique. Which technical tools could improve the clinical diagnosis of melanoma further? And so it has been stated the whole body photography is an opportunity for early detection of melanoma in high-risk patients. So and this concerns those patients who have the atypical mole syndrome. So I myself apply this technique with storing of 16 pictures over the whole body in the computer. And we also use an additional computer program which compares between the moles which we took last time and which we took this time, and this computer program recognizes changes of 10%. You should be aware that around 2/3 of all melanomas develop de novo beneath pre-existing melanocytic nevi, and about 1/3 develops on pre-existing melanocytic nevi. So the majority develops de novo. And so it's important that we screen the total body for newly developing lesions. This is rather easy if somebody has, let's say, 20 to 50 moles. It becomes very difficult in those who have hundreds of moles. And I have many patients who have hundreds of moles. How to perform a biopsy? In suspicious lesions for melanoma, a primary complete excision, an excisional biopsy with a small safety margin is recommended. Small safety margin means 2 to 3 millimeter. And what we try to achieve is the complete excision of the lesion, because for the histopathologist, it is important to see the entire architecture of the lesion. And this makes, let's say, also diagnosis of early melanoma possible. And if you lack the complete architecture, you may miss the melanoma. And so there is no clear recommendation for the technique. So you can take it as a spindle biopsy, but in small melanomas we also take it as a chafe biopsy, enabling the clear diagnosis of the malignant melanoma. Which safety margins should be used for the excision of primary tumors, and this means secondary excision. With curative intention, a radical complete excision with the following safety margins is recommended to overcome local relapses. However, there is no impact of the margin on the survival of the melanoma patient. So it's a matter of local control. And these are the margins which we use today. This applies to invasive melanomas, and we have for melanomas up to 2 millimeter in tumor thickness, Breslow's tumor thickness, 1 centimeter margins. And for those who are thicker, we apply 2 centimeter margins. And there is really not a reason to make the margins larger. So probably when I started with my education in dermatology, we applied 5 centimeter margins to all lesions independent of tumor thickness. It does not make sense. And so this is now a recommendation which is uniformly given in the US, in Australia, and also in most European countries. What about melanoma in situ? So melanoma in situ should be resected with a safety margin of 5 millimeter. Histographic surgery is recommended for lentigo maligna. I come back to this. Now, 5 millimeter. If you have a strong suspicion that this can be a developing melanoma, it may be better to take 5 millimeter immediately. Then if it's a melanoma in situ, you know you have not to do a secondary excision. Yeah? So that's what I normally do if I have a suspicion for a melanoma in situ. If it's invasive, then you have to enlarge the safety margins. Now, in lentigo maligna and acrolentiginous melanomas in the face, on the ears, or on fingers and toes, safety margins can be reduced according to the anatomic localization. Amputation of toes or fingers are not increasing the probability of survival. So, we recommend the so-called histographic surgery. That means we excise and we cut off the margins for special histologic examinations, and we perform a complete examinations of margins in these cases in order to guarantee that the tumor is completely excised. And this seems to be feasible for lentigo maligna and acrolentiginous melanomas. And you see, we have, like you see in this picture, sometimes rather large lentigo malignas which are difficult to excise with safety margins. Yeah, so we try to get them totally out, but we do not apply safety margins. In lentigo maligna melanomas of elderly patients, or in patients with a contraindication for surgery, primary radiotherapy can be used as an alternative. The tumor control rates are excellent and almost equivalent to surgery. So there is not much evidence from the literature. So, but let's say we give a recommendation B for this. And it is seldomly used in Germany now. For instance, it may also be an alternative in this case. Yeah? So at the lower lid eyelid. So then let's say you can functionally preserve the eyelid with a high probability, but radiation therapy is much more time and money consuming than normal surgery, so it should remain an exception. Which parameters should be reported in a histopathology report? We also give recommendations for this. Obligatory information on the following parameters is needed. Tumor thickness according to Breslow. We do not report the level of invasion anymore because it's no longer taken in the classifications. Ulceration, yes or no. And the mitotic rate in primary tumors less than 1 millimeter in diameter, and the mitotic rate is number of mitoses per square millimeter. So, and this enables the staging according to the TNM classification from 2009. Furthermore, unusual findings like association to dermal nevus, signs of regression, or desmoplastic parts, as well as involvement of blood vessels, need to be reported too. So, let's say there is obligatory report for those data which are necessary to classify the patients, and then it is good if the histopathologist reports some unusual findings like regression and others. Now, how to stage the patient with primary tumor? And here we had a long discussion because it was used in Germany that we do either thorax X-rays, or that we do abdominal ultrasound, or that we do CT scans. But we now recommend lymph node sonography should be performed in each melanoma patient from stage 1B, this is more than 1 millimeter of tumor thickness onwards. The evaluation of protein S100 beta, a serum tumor marker in the blood, can be performed in asymptomatic patients. Now, perhaps I would like to supplement this. We recommended clearly that chest X-ray, abdominal ultrasound, and scanning examinations are not necessary in primary melanomas. So we recommend these kind of examinations from begin of local regional metastasis, or let's say guided by clinical findings or elevated tumor markers or other unusual findings. Where to perform sentinel lymph node biopsies? So, with the aim of correct AJCC classification, a sentinel node biopsy should be performed in melanomas with 1 millimeter tumor thickness and more. So, in Germany, this is now, like in many other European countries, a routine surgical procedure with low morbidity. So normally we have an excisional biopsy of 3 centimeter and take off on an average 2 lymph nodes after performing lymphoscintigraphy to identify them, and we also use PET and blue. It's done nearly exclusively in the dermatology department. So dermatologists do the sentinel node biopsy. Probably this may be other in your setting, but we should look that our patients receive it in order to better clarify also indications for adjuvant treatment. Are there exceptions to the sentinel lymph node biopsy indications? If additional risk factors for a positive lymph node are found in primary tumors of 0.75 to 1 millimeter, such as ulceration, mitosis in the primary tumor, or younger age, less than 40 years, we would likewise recommend to do the sentinel lymph node biopsy. I think this is also something that the treating centers should discuss and, let's say, develop their own standard operating procedures for how to deal with these kind of patients. So, there's a consensus-based recommendation. Sentinel lymph nodes should be evaluated by an experienced melanoma histopathologist. Technical evaluation of the sentinel node according to national and international protocols is mandatory. So that means normally the sentinel node is examined by an experienced histopathologist, and for the examination also immunohistochemistry stainings like melan A or HMB45 or protein S100 or several of them should be performed. The following information on the histopathology of the sentinel node should be reported. Detection of nevus cells, which are normally in the capsule of the lymph node, or melanoma cells, which are normally in the subcapsular sinus or in the lower portions of the lymph node are found. In case of melanoma cells, the largest diameter of the micrometastasis in the sentinel node should be reported because this is also a prognostic factor. Now, in stage 2C or 3A to C, we recommend that lymph node sonography should be performed, and as tumor markers protein S100 beta and LDH. And additionally, we now recommend that a PET-CT is superior to conventional CT, MRI, chest X-ray sonography regarding specificity and sensitivity in a meta-analysis. So we, if available, we recommend for these staging examinations PET-CT technology. If not available, we recommend scanning procedures like CT and MRI, and for the brain, MRI provides the best diagnostic accuracy. In which cases is an elective prophylactic complete lymph adenectomy indicated? And the answer is an ELND is never indicated and should be banished. So without the information of the sentinel node, we should not take out all lymph nodes. And for those patients who have positive sentinel nodes, we offer them a complete lymph adenectomy. What is the impact of adjuvant irradiation of the lymph node basin? So adjuvant irradiation can improve the local tumor control, but not the overall survival. There was just a recent trial from Australia and New Zealand published, and it improves the local tumor control, particularly if at least one of the following criteria is fulfilled: more than 3 lymph node macrometastases, extracapsular extension of the metastasis, and lymph node metastasis a size of more than 3 millimeters, so bulky metastasis. So in these cases, we propose to offer the adjuvant irradiation to the patient, discussing with him also the adverse events of this procedure. What about adjuvant interferon alpha? In patients in AJC stage 2BC and 3A to C, adjuvant interferon should be offered. So in Germany, we normally offer a schedule of low-dose interferon, 3 million units 3 times weekly for 18 months. And in patients with AJCC stage 2A, that means more than 2 millimeter in tumor thickness, 2B is more than 4 millimeter in tumor thickness, adjuvant interferon can be discussed with patients. So there is some evidence in the literature that also these patients may benefit, but the benefit is rather small. Adjuvant treatment of melanoma, the following procedures or drugs should not be performed or given. This is dacarbazine. There's evidence from several studies that it does not work. Vaccination outside of a clinical trial. All vaccination trials so far did not show benefits for the patient. Hyperthermic lymph perfusion with melphalan outside of a clinical trial. This has for some time been done, especially in the Netherlands, and a randomized trial showed that it is not of any benefit. And also unspecific immunostimulation with substances like BCG or levamisole or others are not recommended. And all this is based on randomized trials and given with a high level of recommendation and based on a high level of empirical evidence. Has adjuvant mistletoe therapy benefits in disease-free or overall survival? No, this treatment should not be given to melanoma patients, and this is also based on a randomized trial. So, genetic testing in melanoma. I will not speak much about treatment in distant metastasis, but you should be aware that patients who have especially the BRAF mutation, probably also in future the NRAS mutation, can benefit from the new drugs which are now on the European and US market, the BRAF inhibitors vemurafenib and dabrafenib, which will be approved in a few months, and also from the MEK inhibitor tramitinib, which will also be approved in a few months. And so we recommended from stage 3B onwards, so from local regional metastasis. Melanoma patients are tested for BRAF mutations. In patients with acral and lentiginous melanoma and patients with mucosal melanoma, c-KIT testing should be performed. Optional NRAS testing in BRAF negative patients, especially if clinical trials are available, but now there are starting clinical trials in NRAS mutated patients with MEK inhibitors. So we will start such a trial in the next weeks. So we routinely do now BRAF mutational testing, and it is in Germany positive for 45% of the patients. And we now routinely do NRAS mutational testing, which is positive in Germany for 15% of the patients. We do c-KIT testing only in patients with acral and mucosal melanomas, and we find a positivity rate of 5 to 10% in these subgroups, but nearly no mutations in other groups. And those who have the c-KIT mutation can be treated with c-KIT inhibitors like imatinib. Yeah, so they developed a number of new treatments, let's say targeted treatments for these mutations during the last 3 years. Now, there is a consensus that the treatment of stage 4 disease should take the following parameters into account: oligo versus multiple metastasis, low versus high tumor load. And just to make a comment on this, we check in every patient if all the metastases can be surgically removed. And we do this in 25% of our patients with distant metastasis. And they have a clear survival benefit. After 5 years, still 40% of them are still alive. So rapid versus slow tumor progression, mutational status of the latest resected metastasis, and performance status of the patient, and all these should be taken into account when planning systemic treatment. Now, I do not have slides here, but I also would like to inform you about some very recent developments in the systemic melanoma treatment. At this year's ASCO meeting, American Society of Clinical Oncology, which is held in Chicago and visited by 35,000 attendants, there were several new develops for the melanoma treatment. And the main point is immunotherapy of melanoma becomes effective. We already know that ipilimumab, a CTLA-4 antibody, is on the market in Europe and in the US, and it makes about 15% objective responses. It affects the T lymphocytes. It takes off the brake for activation of T lymphocytes, and it's, let's say, an unspecific immunotherapy which is effective in melanoma. Now, in this year's ASCO, it was reported that a new antibody directed to the programmed cell death 1 molecule on the T lymphocytes is more effective. It makes about 30% of objective remissions. And these remissions are, as far as we can see it, stable. So the 15% remissions in ipilimumab remain stable over at least 5 years. And now both have been combined. PD-1 is also an inhibitory immune checkpoint. So PD-1 is activated by ligands which are, for instance, present on the tumor cells. And if the lymphocyte comes, the tumor cell presents PD-1 ligand and inactivates it. Yeah? And so blocking this mechanism makes the T cells much more effective. And both molecules have now been combined. And the response rate was 50%. Unbelievable for an immunotherapy. And the response was rapid. It was within 8 weeks, mainly. And these 53% of melanoma patients who responded, they were not selected, they had tumor regression of 80% and more. So many seemed to develop to complete responses. And so this is a very new development. We get these PD-1 molecules now in the first phase 3 trials. And this will also affect cancer therapy in other tumors. So it is already tested in lung cancer and also in other solid tumors. Maybe that the response rate is not as high as in melanoma, but if it's 30%, it is still a very attractive treatment. So we are now on, let's say, a change of the paradigms of cancer therapy with these new drugs. And what we learned is it's not the specific immunity which is lacking. So all our trials on vaccination and so on, they were without clear effects. It is the breaks, the inhibitory immune checkpoints of the lymphocytes who inactivated the tumor responses, and there is obviously enough specifically against the tumor-activated lymphocytes to achieve very large remissions. Okay. Now I come to the last part, the follow-up recommendations. And here we stated first, self-examination of skin and lymph nodes are an essential piece in the early detection of relapses and secondary melanomas. Patients should receive an instruction for self-examinations. So we normally have brochures also for that, but the doctor should also explain it to the patient. A risk-adapted follow-ups should consider at least 10 post-operative years. And everything I tell now is, let's say, the minimal recommendations. You can do more, but let's say we should at least follow up our patients for 10 years. There are the self-examination and the yearly whole body examination by a dermatologist is recommended. And this is not to detect recurrences, but to detect secondary melanomas for which all melanoma patients are prone. Now, this is the schedule which we recommend now. We have increased hazard ratios, so increased risk for the development of recurrences, mainly in the first 3 years after diagnosis. And so we recommend to do examinations every 6 months in thin melanomas and 3 monthly in the thicker melanomas. And in those patients with 1B to 2B, this is 1 to 4 millimeter in tumor thickness, we go in the year 4 and 5 to 6 monthly, but we stay with narrow periods in those with the very high risk stage 2C and 3 mainly. And in years 6 to 10, we can go either to 6 or to 12 months, but in those with the high risk, we still recommend half-yearly examinations. So what is recommended for these examinations? It's a whole body examination. It is lymph node sonography, mainly from stage 1B. We detect 1/3 of all lymph node metastases by lymph node ultrasound before we can palpate it. We have the serum marker S100 beta, which is rather sensitive for indicating development of distant metastasis. And CT, MRI, PET-CT, we recommend them from stage 2C. 2C means more than 4 millimeter and ulcerated. And this stage 2C has more or less the same prognosis like 3A, that means patient with micrometastasis in the central nodes. Now, just a word, psycho-oncology. In Germany, we developed interdisciplinary skin cancer centers, which are, as a rule, guided by the dermatologist of the respective center. We have now 40 of these centers all over Germany, and they are certified by the German Cancer Society. They have to go through a review process once yearly, and then they also have to present all the numbers of patients with the different diagnoses and so on. And one of the topics which is checked is psychosocial care. And so in our cancer centers we regularly involve now psychologists and social workers for certain questions of the patients. And I think this really improved the care for our patients. So from my experience, I can state that we recommend, especially for those patients who want to have such care, psychology. Okay, so this is the overview. What is the role of the dermatologist in melanoma, and what are the most recent recommendations which we developed in Germany. To summarize, the dermatologist shall guide interdisciplinary melanoma management, and you can look up this guideline in the journal of our society. Thank you for your attention.